diencephalon with the epithalamus. And this morning we'll go on to the hypothalamus. Hypothalamus is probably the most complicated and in some ways the best understood portion of the nervous system. It, come down to the real world, can be covered by a dime placed just behind the optic, just over the optic chiasm tract. So it's a very small structure, right at the base of the brain, in the floor and walls of the third ventricle. And in the sagittal view, with the anterior commissure and the optic chiasm, the mammillary body, the lamina terminalis, pituitary stalk, floor of the third ventricle aqueduct, the roof of the third ventricle, and the hypothalamic sulcus. So we have thalamus bulging towards us into the third ventricle, and hypothalamus below. We will see that the fornix, coming from the hippocampal formation off the temporal lobe, just touching the anterior commissure, dips into the wall of the third ventricle, on its way to the mammillary bodies. As it does so, it divides the hypothalamus in medial and lateral parts. We look at that in a coronal section here. We have the epithalamus, thalamus, hypothalamus, the floor of the third ventricle, the roof of the third ventricle, thalamus, the hypothalamus coming out like so, the fornix, which begins out here in the temporal lobe as the alveus and fibers collect on the medial side and swing back and around. We're going to cut them up here and swing forward. We cut them down here, cut them up here, we're going to cut them in here as they divide the hypothalamus into medial and lateral portions. The lateral hypothalamus is a rather diffusely organized group of cells and fibers. The fibers are running front to back, mostly, as the medial forebrain bundle. Coming from basal olfactory area, septal area, running through the lateral hypothalamus, making synaptic connections that continue on into the descending suprasegmental sympathetic system. It's this system that is released in the decorticate preparation, such that the only response to almost any stimulus of the decorticate cat is sham rage. They spit, hair stands on end, and they have a very limited repertoire of response to stimuli. . So, lateral hypothalamus is relatively simple. Any problems? The medial hypothalamus has somewhat more complicated set of nuclei, and the hypothalamus can be divided into three parts: front, middle, and back. Such that the anterior contains the preoptic and supraoptic nuclei. The middle contains the ventral medial and dorsal medial and paraventricular. And the posterior contains the mammillary bodies and the posterior. Not a very imaginative name. So let's consider each of these three parts serially. I'm going to expand my pituitary stalk to include the posterior lobe of the pituitary, which is neural, and which is going to receive the axons, the supraoptic and paraventricular nuclei. These two nuclei are very densely packed with neurons in a very vascular region. The vessels are slightly leaky. Not as leaky as might be implied with the middle blood-brain barrier, but they have a deficient blood-brain barrier. They allow the neurons to detect differences in concentration of water. And so the secretion of these nerve cells, it travels down in the axon and is secreted at the ends of the nerves onto the walls of the blood vessels of the posterior pituitary, into which they are released. This is arginine vasopressin, an antidiuretic hormone. Which, on demand, goes to the bloodstream, to the distal of the tubules of the kidney for reabsorption of water. So that the renal dialysis made by the glomeruli is then concentrated when this system works. When this system does not work, as in diabetes insipidus, distal tubules cannot reabsorb water adequately. Too much urine is excreted, and the patient becomes dehydrated. So this is one of our introductions to the two phenomena. One, the areas of the brain that have deficient blood-brain barrier, and two, the secretion of hormones into the bloodstream to effect something distally. It's this kind of synaptic transmission with a very long synaptic space that allows for some analogy of the hypothalamus being a motor plate structure. The blood-brain barrier problem we saw a few weeks ago in the posterior hindbrain in relation to the area postrema as the central or centrally acting emetics. Same basic mechanism, deficient blood-brain barrier, recognition by nerve cells of a particular kind of stimulus, and in that situation, a neural reflex for vomiting initiated. Paraventricular nucleus, well, the supraoptic nucleus is, as far as I know, a very homogeneous, essentially single-purpose cell. The paraventricular is a mixture of cell types, one of which is exactly the same as supraoptic, and the other of which is different and secretes a different stuff, oxytocin. So I guess to keep my color scheme straight, I really ought to have a mixture of cells up here for the paraventricular and have it come down green also. Oxytocin is a stimulant of smooth muscle, particularly for uterine contractions and for, at least in pigs, milk let down when the baby pig bangs against the teats and stimulates the mother to produce milk. And I gather, not having seen pigs do this, that there's a gush of milk available for the piglets. And that, whether that's important in the human, I don't know. We've had at least one case of hereditary diabetes insipidus, in which these nuclei were very atrophic, gliotic, and yet didn't seem to interfere with pregnancy and lactation in this 3 generations of women that were involved. So whether the oxytocin component escaped, I can't prove, but at least the other cells were completely atrophic. So here we have a beginning on an analysis of suprasegmental functions in which we're considering afferents to the suprasegmental organ and efferents out, just as we did with the cerebellum and ventriculum. Here, though, the afferent stimulus for the supraoptic paraventricular nuclei is humoral, concentration of electrolytes in blood for water balance, and the efferents are humoral through posterior pituitary to the kidney. So it's a slightly different pattern than we've seen before. The lateral hypothalamus, for those of you who came late, is a more classical neural situation. As I mentioned, the hypothalamus divided medial and lateral, and the lateral more diffusely organized with scattered large cells and a heavily tracked fibers running from base of olfactory septal area diffusely through the lateral hypothalamus at right angles to this diagram on the board, with synapses in the lateral hypothalamus and continuing on down as a multisynaptic suprasegmental efferent sympathetic system. So any questions about hypothalamus so far?
Yeah, what's the afferent for oxytocin release?
I don't know. I would assume there must be something, particularly in pigs, that makes this neural sensory. What the connections are, I have no.
I know it can be released from either manual stimulation or visual stimulation or auditory stimulation. So I guess somehow all three must be hooked into some kind of similar mechanism.
I wasn't aware that visual auditory inputs were important.
They can trigger oxytocin release in lactation like that.
Huh. Well, that just adds a few more, presumably thalamo-hypothalamo connections, or whether the cortex involved, also I don't know. We do have reciprocal connections between medial thalamus and hypothalamus. So one could come in either directly from below through reticulo-hypothalamic connections or from above through cortical, thalamic, intrathalamic connections down. I'm not quite sure how much is involved.
It came from the cortex. It probably only have to come from one place, though.
Oh, what's that?
Well, all the stimulations have to do with young infants. Typically, you've got a mother that hears a baby cry, that might cause them, right? Simply just seeing a baby sometimes can cause no blood down. So, at least it seems to make sense. In your higher centers of comprehension, you've probably got some place where all those things are similar, or some similar location. So an input from that area would be one sort of input instead of having three completely separate inputs, one directly from auditory, one somewhere from visual, one somewhere from manual.
Somehow it appealed to me to have it less specifically analyzed at the cortical level and more of a particular hypothalamic reflex from whatever stimulus is coming in. Just guessing off the top of my head. Hard to get volunteers, I suppose, to corticate. To see what would happen then. All right, next.
Dr. Albert?
Yeah.
The medium forebrain bundle, does it contain all the other things? Building nerve fibers going to the area?
I don't know. Let's look that up somewhere. Any particular reason to suspect it?
Well, for example, in rodents, lesion, there could be DNA destroyed.
I have no information.
Sorry. I think it's sort of the classic model of Parkinson's disease. Well, human, that's in rodents, describe it as a pathway for dopaminergic fibers.
I don't know. Well, let's come to ventral medial nucleus. Ventral medial nucleus is one that can be destroyed experimentally by directly destroying it, let's say by electrical burns, or more interestingly by poison, gold thioglucose. And the result is obesity. Presumably, this becomes then a glucose receptor, and the gold thioglucose poisons that and kills off the cells. And the output, presumably, is descending autonomics to pancreas, among other places, I suppose, to secrete insulin and to modify the respond appropriately to the modulate the blood glucose. There is a corresponding part just laterally in the lateral hypothalamus, which seems to balance this system, destruction of which produces the opposite, and the loss of body tissue, fat. And so the general hypothesis has been that these two structures, ventral medial and lateral, constitute a metabolic balance for glucose metabolism specifically, and for fat deposition or utilization, and the two major syndromes, hypothalamic obesity or the opposite, controlled by these two nuclei. So here we have another combination, presumably, of an afferent humeral and an efferent descending hypothalamo autonomic system.
When you say it's efferent descending, where is it projecting to?
Okay, the hypothalamus can be regarded among other views as the front end of the reticular system, and contributes certainly to a descending set of fibers, several sets of fibers, that come down through the midbrain, pons, patella, spinal cord, as hypothalamo-reticular brainstem, hypothalamo-reticular spinal cord, for sympathetic and parasympathetic connections. I don't know of any specific point-to-point relations. Presumably there are, to account for the different dysfunctions that occur. But we have a rather diffuse descending set of fibers available for that kind of function.
It would seem that it also, sorry to keep standing up for the cortex here, but my understanding was that the animals would become obese if they would choose to keep eating, or eating just was no longer appealing to them. So it would seem to me once again that it would have to go up to somewhere where there was a decision-making process going on, an awareness that before they were choosing, yeah, I feel hungry, I'm going to go eat, and now it just doesn't, or now I feel full and I'm going to quit eating, lose that awareness of the stimulus again. They can go somewhere up to the awareness part of the cortex.
There are probably at least two components to that. One is the conscious appreciation of hunger or thirst, and the other is an unconscious reflex type, or in the situation of the hypothalamus, the concept of a thermostat, which we're about to come to in terms of setting the thermostat higher for body temperature or lower, or setting the thermostat higher or lower for metabolic activities. And that these would be accomplished essentially independent of voluntary.
Well, the thermostat certainly.
I'm sorry.
The thermostat certainly is independent
Yeah.
of voluntary. I don't know about it.
As far as I know, decorticate preparations
Still keep eating too much.
do not become obese. Chronic decorticate cats, for example, can be maintained without paying special attention to diet. Once you get over the acute phase, as though the balance of power is still effectively operating at the hypothalamic level. Dorsal median nucleus, I don't know much about in terms of any specific functions. Posterior hypothalamus has these two major components, mammillary bodies, which is a major hippocampal fornix circuit. And just for completeness, so we have this afferents coming in through the fornix. This efferents is going to go out up to the thalamus, specifically to the anterior thalamus. That's the mammillothalamic tract. And has a bundle going back into the reticular formation as a mammilloreticular tract. As part of the limbic system, which we'll pick up when we get into the telencephalon and discuss the hippocampal formation. But just to remind you that there is this telencephalic input to mammillary bodies through fornix and output to thalamus, which we'll come to next time. Now, the posterior hypothalamus contributes also to this descending hypothalamo-reticular system, set of systems. As though the whole hypothalamus is giving rise to a diffusely organized set of medial, poorly myelinated fibers that are descending to reticular formation and autonomic nuclei. The pattern of connections is, so far as I know, again, not specifically patterned in a point-to-point relationship. But as far as temperature balance goes, a real thermostat, where you seem to have an anterior and posterior division between heat loss and heat conservation mechanisms, such that when you destroy the anterior hypothalamus, temperature rises, and destroy the posterior, you tend to destroy both systems, so that the body temperature becomes more dependent upon the environment and will either rise or fall depending on what one does to cool or warm the patient. So-called poikilothermic pattern. Involved in heat production, of course, is activity, muscular activity, shivering. Involved in heat maintenance is pilot erection, increasing the microclimate insulation around the body, so there's less heat loss. And the opposite of that, vasodilatation, so more blood is brought to the surface, more heat can expand, be lost to this microclimate, and sweating. So evaporation of water lowers the temperature. And the balancing of these various activities seems to be accomplished through the anterior, posterior hypothalamic medial fibers that control temperature regulation. So far, to summarize, the hypothalamus, we have humoral afferents of water, glucose, temperature, and humoral efferents, essentially through posterior pituitary, and neural inputs from olfactory and nearby structures of telencephalon, as well as ascending reticulocollicular inputs, and output systems through descending, largely descending systems, medial and lateral, onto reticular formation and autonomic nuclei. Any problems so far? Well, we should try and finish this off by bringing in some more structures. And I suppose the first one we ought to bring in is the anterior pituitary. Anterior pituitary, colors are off here. Now it's orange. Is, of course, a non-neural structure, developing embryologically from mucosal epithelium of the nasopharynx and being drawn up to the neural protrusion from the floor plate of the diencephalon. So we have anterior and posterior pituitary glandular and neural components fused with each other. The anterior pituitary has no known neural input. And essentially all of its afferents are either directly humoral or indirectly, or most of them, from hypothalamus to anterior pituitary through a small vascular system known as the portal hypophyseal system, by analogy with the portal vein, which has capillaries in gut, large vein, capillaries in liver. We have capillaries in hypothalamus, larger veins to anterior pituitary, and capillaries in anterior pituitary. And so the next question is, how do these releasing factors from hypothalamus, neurons in hypothalamus, get to the anterpituitary. And each of the various hormones that the anterpituitary is going to produce. It will go to thyroid, to the adrenal cortex, to half a dozen other target organs, is going to receive a releasing factor from hypothalamic neurons. So I need to put another vascular channel in here with capillaries. Larger vessels and capillaries again. So the releasing factors from hypothalamus can stimulate the particular cells to produce the particular hormone that one wants. Now that means that the hypothalamus has the capacity to produce these structures, these chemicals, almost exactly the way the supraoptic paraventricular system operates for posterior pituitary, except that the capillary system is higher up in the hypothalamus itself. And the target is the anterior pituitary, a completely non-neural structure. The effective stimuli to the hypothalamus to produce these releasing factors can be humoral, can be neural. The target organs from anterior pituitary are generally rather selectively stimulated by the particular secretion. And there is typically a feedback mechanism, humorally related, so that the production of hormone is cut off. What we see clinically and pathologically these days is most commonly a small tumor that produces prolactin, which then produces cessation of menses, stimulation of lactation, and turns out to be a chromophobe adenoma. Now, pituitary cells come in a variety of types. The acidophil, the basophil, so named because of their affinity for hematoxylin or eosin in classical histology, or neither, the chromophobe. Now this is a gross oversimplification of the 1920s and 30s, when in the days before CT MRI and even, I guess, pneumoencephalograms were just coming in. But the ability to diagnose pituitary tumors was almost purely clinical. And so a large part of the diagnosis required a large tumor. And so it was typically the late stages that were being seen, macroadenomas. And these three types of cells were recognized. As the chemistry of releasing factors and neuroendocrine systems became better defined, And as they particularly became applied to pituitary histology by immunocytochemistry, one could recognize that there's a whole host of different kinds of cells in these crudely stained preparations. And so the first assumption was that the cells that produced the hormone, take prolactin, specific example, produced by acidophilic cells, would be associated with acidophilic tumors. And that turned out to be not the case. It turns out that the staining acidophil or basophil depends on the retention of granules in these cells, which is essentially a storage form of the hormone. And so if the hormone is being produced and excreted more rapidly than stored, the cell will not be acidophil, will not have enough granules to be stained. And so what we're seeing is that the chromophobe is typically a cell that is not exhausted, but is producing more than is storing. So we have a whole host of these microadenomas, in particular, that are very nondescript looking, with ordinary stains, which will stain with one or another of the hormones or antibodies to them. And the classification of pituitary tumors has changed quite a bit over the last couple of decades. It's not at all uncommon to see prolactin producing acidophilic cells that are prolactin producing but not storing, and therefore not acidophilic. And almost equally common for ACTH producing cells, typically basophilic cells, that are producing, secreting more than they're storing, and are chromophobic. So the experience of the last couple decades, and we've been seeing at least one of these a week, I guess, for 20 years. The early experience was very troubling because they all came from chromophobic. And yet, Bill Kelly in particular was saying, well, these are pretty symptomatic patients. And eventually the ICC techniques straightened it out a bit. So any questions, comments about this general area? There is one cell that I've left out, and that is the cell that truly could be called a chromophobe, a null cell producing nothing, or still another cell that, for reasons not at all understood, is accumulating mitochondria, so-called oncocyte. It will frequently stain as though it was acidophilic, because these mitochondria are granular and tend to be a little more eosinophilic than the rest, and so one can make a slight mistake with oncocytomas, which are non-active, or with null cell adenomas that are truly chromophobic and inactive, as well as with the chromophobic poorly storing cells that are producing one or another of the hormones of the pituitary. Any problems?
question, you mentioned a feedback mechanism. Does that function through areas that also have insufficient or blood-brain barrier, and where are those areas?
That I don't really know. In a way, it would help allow the hormones more direct access to the neurons. Except in a way it doesn't help so much because the blood-brain barrier deficient areas are specifically in paraventricular supraocular. The rest of the hypothalamus is not particularly so. So I can't make it too generalized. I don't have the vascular holes to allow it. Well, if you've stayed with me so far, I should put in another piece of this blood-brain barrier problem and the water balance problem. Let me put in somewhere here. I need to put a posterior commissure back in this drawing. So I've got the floor of the aqueduct, we need the roof of the aqueduct. Down here with a posterior commissure here. And a little structure in the roof of the aqueduct. Known as a subcommissural organ. Now, if we look at this in a horizontal section, say through the aqueduct, very aqueductal ray, and midbrain. In the roof of the aqueduct, there are some cells that make a little indentation in the roof here. That are different from the rest of the ependymal cells of the aqueduct. And they are oriented such that they're supposed to secrete aldosterone. Aldosterone stimulating factor, I think it is. In the blood vessels, circulated to the adrenal, which then secretes aldosterone. Malaria zone of the adrenal. Then goes to the kidney through the proximal tubulus for reabsorption of sodium. So between these two portions of the renal tubular reabsorption system, we have one through the subcommissural organ, adrenal, and aldosterone, and the other through supraoptic nucleus, postpituitary, antidiuretic hormone, distal tubule, and reabsorption of water. And these two mechanisms are supposed to maintain proper balance in overall concentration of water and specific concentration of sodium. And if they work properly, operate properly. If we make lesions, though, in the system, producing diabetes insipidus over here with the supraoptic hypothalamus system, ADH, we're also supposed to be able to make lesions in the subcommercial organ and interfere with the absorption of sodium. Leading to shock and death in a matter of about 5 days or so. Experiments been done in dogs and rats, I believe. I don't know whether these are seen in humans or not. But it's supposed to be one of the mechanisms for water electrolyte balance. And you mentioned, Ray, the problem of hunger and thirst, recognition of those. The recognition occurs at a more conscious level, but these control mechanisms at a subcortical, hypothalamic, or closely related system. But this subcommercial organ is another one of those little structures that has a very poor blood-brain barrier. And now, just to finish off the subcommercial organ, there's supposed to be a secretion in the opposite direction. Which is said to go down through the aqueduct, fourth ventricle, into the spinal cord, as a fiber. What's the guy's name? I keep coming up with something right there. Rikers. I think that's right. It's supposed to go all the way from the posterior commissure down to the bottom terminal in the whole ventricular system. And that is so preposterous that I only mentioned it to say that it received serious study by a serious neuroanatomist who spent 20 years studying it. And so there might be something to it. What is function, or why it can't be seen by ordinary techniques and required silver precipitation of silver, histologically to show it, I don't know. But it does add a little fanciful early morning component to a very small structure, subcommercial organ. In 3 minutes, Mike, can I do the pineal? I'm tempted, because I've got 2 neurosurgeons available, to ask if they've ever seen the neural connection to the pineal, which is said to be let me put it in the tentorial notch here. We have dense dural tissue surrounding the midbrain, tentorium. And coming back here from the back end, we have the pineal. Which lies just below the pendular commissure and just above the posterior commissure, which itself receives no neural connection from either of these immediately adjacent, fairly large structures. It is said to receive both sympathetic and parasympathetic innervations by fibers that come up and run in the tentorium edge and cross through subdural, arachnoid, subarachnoid, as coronary nerves to innervate the pineal. I'm glad to see at least a frown on at least one of my neurosurgeons. But there are two sources of these. One is sympathetic from the superior cervical ganglion, and therefore afferents from thoracic 1, 2, 3 mostly, sympathetic preganglionics, and the parasympathetic coming from the salivary nucleus through the greater superficial mucosal nerve, heading back onto the tentorium, and ending on a second kind of cell in pineal, thought to be the equivalent of a post-ganglionic parasympathetic neuron. And if the coronary nerves exist, I leave that as a challenge to Steve and Mike to confirm or deny sometime, maybe like next Monday or so. It would allow control of pineal function through autonomic nervous system, for which there is evidence experimentally that one can, for example, take out the supracervical ganglion and interfere with the daily variations in appearance at ordinary H&E's stain level, or chemical, in terms of concentrations of pineal hormones, metabolically by labeled phosphate, say, turnover. So there's several different ways of looking at the pineal and its diurnal changes, influenced by light. We haven't come to the visual system specifically yet. We'll very shortly next week. But the pineal seems to be regulated by day-night light cycle through some system like the coronary nerve, sympathetic and parasympathetics, that can change the activity of pineal cells.
Is this why in congenital learners one eye can be blue, the other one will be dark if they meant to be dark hereditarily?
Really? Haven't heard of that one. I don't see how that would quite go through the pineal. I can understand it going to the pigment in the iris somehow, but I haven't heard that one today. You have to show me. So, the pineal is another one of these structures that has a very deficient blood-brain barrier. So presumably has access to humoral factors that further remain totally unknown. One of my old teachers back at the FIP, Lent Johnson, some years later after I left the FIP, back in 1950, was at a visiting back in 1970, 20 years later, ran into him. And he asked me with a smile what the function of the pineal was. And I smiled back, I don't know. He said, well, I'll give you a big hint. It lies between the great veins of Galen. And with that, walked off. And 20 years later, I'm still trying to see what that clue was supposed to lead me. But I think Jonathan, or someone asked last week about the internal cerebral veins. And they do come right over the pineal. Again, what their function would be, I don't know, in relation to the pineal. Maybe they would have some kind of a vascular connection with our coronary nerves to reverse this case. We'll find out next Monday when Mike is see the report back. So see you then.